Welcome, folks, to the 2023 Healthcare Now Medicare for All Conference. This is the OnePayerStates State of the States Saturday panel discussion and question and answer from 4:15 to 5:15 Eastern Time. We will repeat this workshop tomorrow from 2:30 to 3:30 Eastern Time for anyone interested in returning or recommending others to attend. My name is Chuck Pennacchio, and I'm president of OnePayerStates. Just on background, we are a 14-year-old consortium of 22 state campaigns, or 22 states, some with multiple campaigns. We've been working together for that time period since 2009. And we've had a great deal of success over the years, connecting with one another, sharing resources, building up each other's morale. And this is a continuation of that work. About 5 years ago, OnePayerStates reorganized herself from what was a rather loose coalition of monthly phone conferences into a 501c4. And we jumped on Zoom about 3.5 years ago and have been meeting more regularly. And we reorganized ourselves in terms of work groups so that our work is much more efficiently done. And for folks who are attending today and interested in getting involved, we do work that centers on policy, outreach, education and advocacy, communications, organization development. And so we welcome folks to reach out and to learn more. And I'll drop my email into the chat, but the web address is all over the place here. We've got it placed in a number of different places, but we'll make sure that that gets out to people. So on background here, we have a 2025 target year of implementing truly comprehensive, guaranteed universal healthcare systems in at least 2 states, with the nation soon to follow. We are proud to update what's happening in a number of states today. And folks will come up and do so in like 3-4 minute chunks and bring you up to speed on the states of Colorado, Massachusetts, Maine, Minnesota, New York, Oregon, Pennsylvania, and Washington. The work that we do is based on our applied theory of change, that learns from Canada, where many of you know the province of Saskatchewan led the way to national Medicare for all for our friends to the north. Our theory of change is also based on our own history of social change, as captured in the progressive and New Deal eras, which involved state modeling, which led to national labor, suffrage, and healthcare advances, among others, as well as coalition building based on shared values, intersectional justice issues, strategic visioning, planning, and execution. We're leading the way of a multi-state, 2-track, meaning state and national, campaign for success. Complementing the remarkable work that's being done at the state level is a work relationship that we have with members of Congress. Previously, Representative Pramila Jayapal, who introduced the State-Based Universal Healthcare Act, and now it's being carried by Representative Ro Khanna of California. The State-Based Universal Healthcare Act, which we abbreviate to SBUCHA, of 2023, will soon be reintroduced. But it was known in last session as HR 3775, and the language would be very similar. So that's House Resolution 3775 from the 2021-22 Congress. We fully intend to get this legislation passed in 2025 to provide as seamless an implementation of state universal healthcare plans as possible. That means that we want to get financial waivers as well as an ERISA waiver, which is Employee Retirement Income Security Act, which will keep the states from being caught up in the court system. ERISA, E-R-I-S-A. You can just Google that and you'll find it, E-R-I-S-A. And then today you'll be learning more of how you can support this critical work at both the state and national levels. And you can find information in the meantime at OnePayerStates.org. And having said that, our strategic work truly begins with the organizing credo of radical hospitality, radical hope, and radical love, whereby universal transformational justice is not only possible, it is inevitable. So the legislation that we'll be talking about more on the back end here is the national legislation with Representative Ro Khanna, and we will return to that topic and bring an update as to what's happening there. But for now, we're going to pivot to Barbara Pearson, who's out of Massachusetts, and Barbara has the special role in OnePayerStates of being the curator of the states and the activities that are going on at the state level. So Barbara, do you want to give us a quick overview as to what's happening?
Okay, can you see my screen?
Got it.
Okay, so I'm the curator of the map, not the states, okay? And this is the map. It's a snapshot of the state-based single payer activity at around this time, as much as we can tell from people telling us. So basically, these are the active states. I think I see one or two errors. I'm looking more closely. And I had hoped that this could be, live online, but I didn't trust my internet to do that. So I'm just going to show you that when you come to this state, you hover on a state and it will get dark, see, as if I had hovered on Maine, and then it comes Maine, and you can say double click. But there's also a place on the menu bar to get to this as well, states, and this is the interactive map. I'm going to go back up one because this one is wrong. So basically, these are states that have current bills, to my knowledge. People can correct me from today, and tomorrow we will be more correct. So California, Maine, Massachusetts, Minnesota, New Jersey, New York, Oregon, Pennsylvania, Rhode Island, and Washington. And then Connecticut, these are ones that have had them recently or are in the process of having analysis studies and so forth, like Connecticut and well, you'll hear about Colorado and later, so the others. So this is, you can see down here at the bottom, this is the OnePayerStates.org states, and that will bring you to this map. In addition to working on legislation in each of those states, we have states that have the possibility of using a ballot issue. And one of the things that you can click on from our interactive map are states that have the option of using different kinds of ballot initiatives. So Maine and Washington have used them in the past. The pandemic kind of got in everybody's way, surprise. And I know last year and several years before, Massachusetts has been running several non-binding ballot campaigns in various districts. So we chose districts of non-sponsors and then had their towns have it on their town, and then everybody passed everywhere. And so then we have a really good lobbying and bird dogging tool showing that your town, your district voted for this. We're also working on regional efforts, especially in the Pacific Northwest, Washington, Oregon, California, and possibly Hawaii. And we're also working in Vermont, New Hampshire, well, New England, to try and do that. So we can talk more if we'll find out from today. I don't want to talk too much because I have so many colleagues that want to speak too. We also have policy people with OnePayerStates who have been very, very helpful in terms, especially Kip Sullivan from Minnesota, who understands, who has made a taxonomy of the different kinds of bills. So not all the bills are the same, but anyway. So now I'm done for now, unless somebody has a question for me. And I guess, should we just go to Colorado?
We'll bring up our leader in Colorado, Lydia Guzman, Healthcare for All, Colorado. Lydia.
Thank you, Chuck, and thank you for the opportunity to speak today from OnePayerStates and Healthcare Now. My name is Lydia Guzman. I'm president of Healthcare for All Colorado, and I'm on the OnePayerStates board. I'm here just to update you on what's going on in Colorado because we are really thrilled and excited about the latest developments that are happening. But before I tell you about the current bill, I want to tell you a little bit about the prior work that was done with my representative, Emily Sirota, and Senator Hawkins Lewis. There was a Healthcare Savings Act bill of 2019 that created a task force that selected an analysis team to do a cost analysis. And they evaluated 3 systems, the current system, a multi-payer system, and then single payer, publicly financed, privately delivered option that provided universal healthcare coverage. Needless to say, that study resulted in the fact that a fully publicly funded and privately delivered healthcare system that covered everyone in Colorado yielded significant savings. So we built on that work. And now we're in a current year, if you can change the slide. House Bill 23-1209 is analyzed statewide publicly financed healthcare. And this bill currently has passed through the House, the subcommittee, the Appropriations Committee, the full House. It has been introduced in the Senate, and it's going to the Subcommittee of Health and Human Services next week on Thursday. So we're thrilled about that. But this bill will conduct a detailed analysis of the feasibility of creating a publicly financed, privately delivered universal healthcare system in Colorado. And it will look at how to finance a system and what the impact to the economic sector would be. It's said to be a holistic study of the cost and delivery of healthcare in Colorado. So it will look at some questions. It will look at how could a universal healthcare system in Colorado, what would that look like? What would be the impacts on the healthcare workforce? What would be impacts to the individual and community health? Where are the current gaps in healthcare, and how could a single payer system address these gaps? So knowing about the prior study and the same analysis team that did that study will be doing this study, we're thrilled to death about the progress we're making in Colorado. I also want to just shout out OnePayerStates for your support, Colorado PNHP, the Colorado Foundation for Universal Healthcare, Healthcare for All Colorado Foundation, Healthcare for All Colorado Advocacy Board, and all of our grassroots supporters, because after this bill passes this year, we're looking for a ballot measure in 2025 or 2026. Thank you.
Terrific. Lydia, thanks so much. And Barbara for doing the overview previously. If folks have questions as we go along here, you want to do resource sharing, feel free to use the chat. And yeah, thanks for the shout outs. Really, I failed to do that at the very top, but thanks to Ben and Julian, especially for bringing us in to have this opportunity to share what's the exciting work being done at the state level. Next up, we've got Barbara Pearson coming back up to talk about Massachusetts for a few minutes. Barbara?
Yeah, so I'm just going to share. MassCare is our coalition. We have had legislation in both of our houses every year. It gets introduced every other year, and it stays there for 2 years. So we got it in January before the deadline. And so there's a House bill and a Senate bill that will guarantee equitable health care for every resident of the Commonwealth through a single payer healthcare financing system. And it's everything you've heard. Coverage will be comprehensive, affordable, no co-insurance, no co-payments, deductibles, or other forms of patient cost sharing. In 2021-22, we had 82 of 200 co-sponsors. Our goal for this session is over 100, which it should hopefully take us over. And we're also, of course, targeting the leadership in the House and the Joint Financing Committee. We have a coalition of over 80 organizations. If you come to our masscare.org website, under About, it lists the 80 member organizations, the unions and advocacy groups and so forth. Some healthcare had advocacy groups as well, including the League of Women Voters, which I'm very proud of. Okay, November, and then we had, I already told you about the non-binding ballot questions that we did in we did through Mass Care in 20 districts around the state. And so we're using those now, getting ready for our lobby day, which is going to be in the beginning of next month. And we're trying to make sure we have a constituent from every one of those districts where they voted in favor of the thing. So we do have a financial analysis of the vote of the bill that's right on the website and the Google report. So when we make these slides available, there'll also be a bunch of links for all of the states that are talking. Some of them will get in the chat today, but it'll always be available to you from the OnePayerStates website. So basically, we have Jerry Friedman, who lives in Amherst. We also have Bob Pollan, who lives in Allen, but Jerry did the state analysis, and he's just updated it again in February for the most current bill. And we're very lucky he gives testimony, so we're assuming that if in fact we get another hearing, he will be one of the ones doing the testimony. So I'm going to leave it at that. There's plenty of activity happening. We need as many people as possible, but there is a lot of momentum in Massachusetts. Hopefully we'll get over the hump.
Thanks, Barbara. Yeah, and again, folks, drop your links for your organizations in the chat. Lynn Cheney from Maine All Care. Lynn?
I'm going to stop sharing while we're doing that so that you can see Lynn. And I can also put things in the chat for people.
Well,
Maybe
as Chuck said, I serve on the board of Maine All Care. We're a nonprofit that was formed in 2010, and we're the only entity in the state that's established for the sole purpose of promoting the establishment of publicly funded health care for all Maine residents. There have been efforts over the past 20 years to implement state-based universal health care in Maine. These include 2 major fiscal studies that show that such a system would be economically feasible. We came close to having a single payer bill in 2014, which was passed by a significant margin in the legislature, but vetoed by then Governor Paul LePage, and came up 4 votes shy in the override. In 2020, we formed an advocacy arm to mount a ballot initiative, but the effort was halted largely due to the difficulty of gathering the required number of signatures in the time of COVID, which has been mentioned. It was sad. We worked hard and it just didn't happen. In 2021, a comprehensive health care bill vigorously supported by Maine All Care was drastically amended at the suggestion of a smart, politically savvy chair of the Legislative Review Committee, and was voted out of committee as ought to pass. The amended bill is short and sweet. It creates the Maine health care plan to provide all medically necessary health care to all residents in the state, and forms a board significantly with no insurance representation to oversee the planning, implementation, and administration of the plan. This bill was passed by a majority of both the House and Senate and became law without the governor's signature. But, and this is a big but, this bill may not be implemented until the state obtains a waiver for a state-based universal health care plan and receives federal financing to support the implementation of such a plan. California Representative Ro Khanna's State-Based Universal Health Care Act, SBUCHA, is the intended enabling legislation. And this means that Maine is in a unique position to have a universal health care bill that's triggered by SBUCHA. In the same session, the Maine legislature passed a joint resolution calling on the president and Congress to establish a federal waiver process for states in order to enable state-based universal health care plans. It specifically calls out the SBUCHA bill. And I suggest that other states might convince their legislatures to do the same thing. I think that would help the passage of SBUCHA and would probably help the states as well. And it was something that passed easily in both the House and Senate, and by a wide majority. A constitutional amendment that establishes the right to health care in Maine is before the current legislative session, and a hearing has yet to be scheduled. It will require a 2/3 vote in both chambers, and Maine All Care will testify in favor of this bill. And finally, Maine All Care recently contracted with the Maine Center for Economic Policy to update a 2018 fiscal study, and we'll be using this information to draft a plan with input from stakeholders and with the hope of submitting a comprehensive bill in the 2025 Maine legislative session. So I'm going to put links to the various studies and bills that I've mentioned in the chat, as well as a link to Maine All Care, which has a lot of resources in it. I'm happy to answer questions at any point.
Terrific. Thanks so much again for the exciting updates, Lynn. And there's a question that came to you in the chat if you don't see it, and also to Lydia. Next up, we have Ann Jones, Healthcare for All Minnesota. Ann? Unmute.
Am I doing this correctly?
You
Yes.
look good. Rock and roll.
Okay, so Ann Jones with Healthcare for All Minnesota. I am a retired registered nurse over many, many years. Decided to spend my golden years working on fixing how we pay for healthcare. Chuck said I thought I should have a story, but I thought if I wore the hat that I wore to an event that I did today, you couldn't forget what I said today. Well, it was a women's Rotary event, and I'm hoping to get a speaking engagement with them. Women business owners and entrepreneurs, I think, ought to be interested in this issue. So we are closely partnered with Physicians for a National Health Program and the Minnesota Nurses Association here in Minnesota. We reconstituted. Healthcare for All Minnesota went dormant in 2014 after the ACA passed, and they just weren't making any progress. We reconstituted with a new board in 2016, focused more on visibility, building our base, and getting out to events to build up numbers. So after 10 years with divided government, the Minnesota Democrats, which are the Democratic Farmer Labor Party here in Minnesota, held on to a small majority in the state house and captured 1-seat majority in the Senate. For the first time in 10 years. We also hold the statewide offices as of 2022. I held on to those. In early 2022 also, which we think will be helpful, all Democrats, of course, formed what they're calling a Minnesota Health Plan Legislative Caucus, specifically focused on getting a state-based plan passed in Minnesota. So we finally, for the first time, we have a longtime champion in the state Senate, Senator John Marty, who has written legislation for a publicly funded and administered universal healthcare system. This was reintroduced this year, just recently, with a new House, with a Senate sponsor and a new House sponsor. So we've also new for us this year as an organization was to take the step of creating a statement of legislative priorities and sending them to the Speaker of the House, the Senate Majority Leader, and the chairs of key committees. We've been connecting with these committee chairs and leaders and other advocacy organizations and issues organizations to support legislation that represents steps toward real progress. Let's see, is this not moving? What's the tendency toward what's politically feasible is a huge barrier to a real fix on this issue. Everybody on this call knows that. The best example I have is that we have a basic health plan in Minnesota. We're one of only 2 states that has that. We were allowed to preserve that after the ACA passed, and it's called the Minnesota Care. It was supposed to be a stepping stone towards single payer system for Minnesota. That was 30 years ago. So we were, as I said, we were allowed to keep this plan. Eligibility for Medicaid and Minnesota Care is still pretty low. Most people without employer-sponsored coverage are still forced to use the exchange, which of course was established in 2013, 2014. These are with commercial plans with a lot of financial risk in many cases. Democrats lost their majority in 2014, advocates stepped back, and costs just go up. So we've kind of taken the approach that we would try to teach both legislators and the public that there are that incrementalism is different from real progress. Are there steps we can use to get toward our desired goal? Yes, but we're trying to teach both legislators and the public how to recognize the difference between incrementalism and progress. And we drafted a set of principles that we want considered for actually focusing on bills that will get us moving in the right direction. So our top priority is to pass this year is our end goal, of course, is a Minnesota health plan, state-based universal health care coverage for Minnesota and a national health plan. We're actively working in that direction. Our top priority is to pass and fund a comparison of costs and benefits of a universal healthcare system. This has been introduced, funding has been determined, and likely will be moved to what they call the HHS Omnibus Bill for debate and action. We expect it to pass, and we expect that we'll be able to assign that to an economist in Minnesota to work on. Other bills allowing undocumented persons to participate in Minnesota Care are moving toward passage. A bill with bipartisan support, which is kind of interesting, named the Freedom to Choose bill, would allow Medicaid recipients to choose fee for service rather than a commercial insurance managed care plan, which would help get the insurance industry out, at least for some people in public program. Another bill that requires a facility organized as a nonprofit to return charitable assets to the state if sold. We've got a big problem here in Minnesota with a proposal to merge with an entity in South Dakota. We need to hang on to our academic medical center. And then, of course, there are some proposals to reduce the cost of prescription drugs. It was recommended by a task force sponsored by the Attorney General a couple of years ago to set up a prescription drug affordability health, a board to control the price of prescription drugs. That's under some consideration, but needs to be stronger. And then we are also supporting and asking our members to support bills introduced by allies in the BIPOC communities and gun prevention advocates to help, build relationships with our allies. Everybody knows the bill attracting the most attention from the DFL legislators and other progressive advocacy groups is a proposal to expand Minnesota Care, our basic health plan for lower income working Minnesotans, as being called the Minnesota Care Public Option, formerly called a buy-in. The rationale is that this tends toward the politically feasible argument and a belief that it could be implemented more quickly and that it would be a step towards single payer solution that we really want. Most people listening today know the pitfalls of the various public option proposals at the state and federal levels. The bill as written has some positives. We have some concerns, and we're trying to communicate those to sponsors and supporters of this bill without alienating current and future partners for reform, which I think is always a tricky solution for advocates of real reform. Our primary strategy, until we can get some hearings and move forward toward real reform, is to work toward building political power by inviting like-minded organizations to join us in coalition. And we are actively building that coalition right now to craft a campaign for a bill and pass and implement the Minnesota Health Plan. So just a little description of the steps we've taken. We're also working on city council resolutions. We've got 7 passed so far. Continue to volunteer at public events and do a lot of base building and working on relationships with legislators and candidates to increase our influence at the Capitol. But we really need the public to push.
Yeah,
This I will end with quickly is a story worth reading about an incident involving a young man who was denied the care he needed by United Health Group, big, incredibly profitable insurance company here in Minnesota. And little detail about that. Yes, my closing thought for all of us is that we really have to build the empathy we need from the public and the sense of urgency to demand change and to combat this healthcare as a business and stop tolerating. I will end with some contact information.
Yeah, drop your links in the chat in that article.
Okay.
That'd be great. Yeah, we have to move on a little. Yeah,
Thanks.
thank you. We'll take some of this up on the Q&A, and that article centers on a young student at Penn State University, by the way. Let's see. Next up, we have Morgan Moore with PNHP New York Metro chapter, newly inaugurated executive director there. Morgan, thank you.
Thanks, Chuck. Good afternoon, everyone. My name is Morgan Moore. Give me just 1 second. I got to get my screen open. I use she, her pronouns, and I'm the executive director of the New York Metro chapter of Physicians for National Health program. And I sit on the steering committee of the Campaign for New York Health. I've been involved in organizing for the New York Health Act for around 7 years. But as some of you likely know, the New York Health Act was first introduced in New York in 1991. After nurses with the New York State Nurses Association Union persuaded Assemblymember Dick Gottfried to author and sponsor the bill. And 32 years is a lot of time to cover in such a short time that I have today, but I'm going to do my best to hit some of the highlights. There's obviously a lot more going on as well. Since its first introduction, the New York Health Act has passed the Assembly 5 times, most recently in 2018 with a 2-to-1 majority, but it has yet to be brought to the floor for a vote in the state Senate, despite the fact that a few years ago we achieved Democratic supermajorities and have majority support for the bill in both chambers. In 2019, the New York Health Act was amended to include long-term care, which was the result of organizing in collaboration with disability rights and senior advocacy groups, and makes the New York Health Act unrivaled in regards to comprehensive coverage. The bill also includes reproductive care, including abortion and fertility care, gender affirming care, and covers everyone regardless of citizenship status. No public programs, no for-profit private plans, no union plans, and no other current proposals can compete in New York State. 1 second. We've been able to make the progress that we have on the bill in the last several years due to strong grassroots organizing across the state, and that's been facilitated and coordinated under the leadership of the Campaign for New York Health through a distributed organizing model that empowers activists, both individuals and organizations, to organize around the bill in the ways that best suit them locally. We employ many different strategies and tactics in our organizing in New York. And so I just wanted to share a few slides from various events and actions and initiatives as examples and inspiration of what we've been up to. Throughout our organizing, we've focused on using the power of our stories to move people at their emotional core and demonstrate the interconnectedness of the various ongoing fights for justice and deep need for systemic change. We've focused in particular on uplifting the experiences of marginalized people and communities who are disproportionately harmed by our profit-driven healthcare system. Our chapter of PNHP New York Metro holds educational forums currently held virtually to illustrate monthly, and we use those to illustrate the connection between the fight for single payer and the fight for health justice and human rights more broadly. Our organization and many others are also involved in organizing various universal healthcare town halls, community forums, teach-ins, film screenings, and tabling at various events. We also helped organize public hearings across the state a couple of years ago. We've held demonstrations. We continue to hold demonstrations, participate in marches, create interactive art experiences. We hold dance parties. We just had our 2nd annual New York Health Act bike ride through New York City. We do bird dogging. We've held die-ins and direct actions. We also annually hold a New York Health Act Lobby Day in Albany, mobilizing hundreds of people across the state to go and speak with our legislators. Here are some photos from some of those days. The last couple of years, they've been largely virtual, and so that's been a new experience for us, sort of transitioning into advocating, in a digital space. Our media strategy has also pulled from the power of our stories. Last year, our chapter launched a social media campaign called Med Story Monday, and you can see a couple of examples on your screen now of that. And advocates have had a number of successes getting op-eds and letters to the editor printed. We've even gotten a single payer mentioned a couple of times in the New York Times, which is really exciting. And some of those examples are also on the screen. This past year has really been a transitional year with leadership changes in Albany. While Senator Gustavo Rivera remains our steadfast lead sponsor and champion in the state Senate, Assemblymember Dick Gottfried, our lead sponsor and author of the bill in the Assembly, has retired this past year, and Assemblymember Amy Paulin has replaced him as both the Assembly Health Committee Chair and sponsor of the New York Health Act. Rivera and Paulin have indicated that they'll be making some amendments to the bill before reintroducing it this session. And we expect that to happen sometime after our state budget is finalized. But frankly, the budget is testing everyone's patience this year. It's now over 3 weeks past due. And it's holding up all of the other matters until those negotiations conclude. New York State's legislative session ends for the year on June 8th. So there's going to be a lot to squeeze in a very short amount of time between the end of budget and June 8th. From our meetings with both of their offices, we expect that the amendments they'll be making will focus primarily on addressing labor concerns. And we're really looking forward to being able to review those amendments. The campaign's prior co-directors, Yulin Koshu and Ursula Razum, stepped down early in the summer of last year. And after an extensive search, the Campaign for New York Health has just this month hired a new executive director. So stay tuned for a big announcement to come from the campaign about that. We've, just as a little background, have had 2 economic analyses conducted of the New York Health Act, and I understand that there's another one currently in the works. Our chapter is also circulating a petition for New York City residents asking our city comptroller, Brad Lander, to conduct an analysis of the bill's impact on the New York City budget. There is also some really great labor organizing happening in the state. We have a new cross-org New York Health Act labor group beginning to meet, and some exciting organizing is being done by rank and file members. In particular, the UFT Moore Caucus has put out some incredible videos, and I'll share some links to those shortly. And lastly, I'd like to say, we really reject the attacks that are happening now on our existing public programs in terms of privatization and the attacks on the LGBTQ community, abortion rights, communities of color, people with disabilities, and the poor, and feel that we really must provide truly comprehensive universal care that's free at the point of service to eliminate barriers to care and eliminate the tiered and segregated insurance system that gives cover to and enables racism in medicine and really harms us all. The best way to keep up with the campaign is by signing up for their mailing list on their website, and I'll drop links to that as well as some other information into the chat now. Thanks.
Okay, Morgan, great visuals. Thanks for that. And yeah, everybody keep dropping links into the chat. And then at the end here, folks, be sure to save the chat, all this great stuff. And in the interim, you can actually open the hyperlinks if you don't know, if you want to take some action. We are asking for support for the work that we're doing at the state and national level. We're an all-volunteer organization as OnePayerStates. Next up is Linda Krieger out of Corvallis, Oregon, to speak to the work being done for Healthcare for All Oregon. Linda?
Thanks, Chuck. Yes, we've been having some exciting things going on in Oregon over the last several years. I'm Linda Krieger. I'm with the Mid-Valley Healthcare Advocates group here in Oregon. And our group has been working for over 30 years to support and implement universal healthcare or single payer healthcare in Oregon. I think persistence and patience are 2 of the watchwords that have been underlying the work done here in Oregon. One example of that is the value statements that we have been continuing to maintain throughout this campaign. And those are actually codified in the language of the bills and the other legislation that's been moving forward. No, that's okay. In the last several years, as I said, we've been working for this for over 30 years, but in 2019, if you'll change to the next slide, Barbara, in 2019, we did pass, our legislature passed Senate Bill 770, which established the Joint Task Force on Universal Health Care in Oregon, and a very hardworking group of task force members put together a detailed report that was presented in 2022 last year that shows the detailed benefits and cost savings. So there was a lot of work done to do a detailed financial analysis. Meanwhile, in I'll call a parallel action, Measure 111 was passed by Oregon voters in 2022. And that was a ballot measure that actually amended our state constitution, declaring access to affordable health care as a fundamental right in Oregon. And I think that was a real message to our state legislature that this is something that Oregonians are interested in and willing to fight for. Probably most exciting is what's happening right now. Senate Bill 1809 has been introduced this year in our state legislature. It's based directly on the Joint Task Force recommendations to establish a universal health plan governance board to get this work through the next steps and to implement or to present a plan for implementation of a universal health plan no later than September 15th, 2026 to our state legislature. Excitingly, that has been just last Thursday, that was passed out of our Rules Committee and is now headed for our Joint Ways and Means Committee. So that's serious progress we've made there. Just a few ideas about how we've made this progress and what we're doing going forward. We have, it's 1089. I'm sorry. I've got the wrong numbers here in my slides. I apologize for that. It's 1089, not 1809. 1089. What we're doing right now is really trying to stay focused, again, with that patience and persistence. Stay focused on passing 1089, continuing to work with sponsors and supporters in Congress, as well as to maintain flexibility in those funding requests and work with people who have concerns about that funding, and organizing as we get closer to a floor vote, organizing the grassroots efforts to get our decisions and our needs known to the legislature. Once that's passed, we want to shift our focus to actually appointing a qualified executive director for that board, because that'll be really important. Getting the Universal Health Plan board put together, hiring staff, getting consultants, doing all the things that will really allow us to move this forward. And then staying engaged with that board as we did with the Joint Task Force. So one of our efforts in advocacy is to stay engaged with that board. We do recognize that there are some challenges we will need to meet as we move forward. Getting the funding that we need to do the bill, the work called for in SB 1089 is going to be a challenge that we're ready to continue to work for. The ERISA challenges that others have talked about, we believe that we have ERISA proofed our bill to the extent possible. And there's a great study done by Aaron Fuse Brown and Elizabeth McCuskey that I'll put a link to that talks about how to do that. We will rely on waivers, of course, to continue our federal funding. So we rely heavily on that federal funding, and we will need to work hard on those waivers. And then finally, working with the public. Nobody wants to increase taxes, and taxes are a difficult thing to get people on board with. But we are convinced, and we think we can convince our public that the cost of doing this and funding this will be much less than what they're currently paying. Both employers and employees will be much less than what they're currently paying to cover their healthcare needs. So that's where we're at in Oregon.
Terrific, Linda. Thanks so much. Really good news coming out of Oregon, getting through the Rules Committee, and then potentially getting a vote done by June. This is you're fast tracking. I mean, this is really critical. That's why we need to align the work that we're doing at the national level with Congressman Khanna, and we also want to get a U.S. Senator running that bill. In the interest of time, I'm going to bounce over. I'm going to skip past PA for a quick second, other than to say that we've identified our House and State Senate leaders. Remarkably, Pennsylvania won the State House. No one saw that coming. We did a clean sweep in Western PA. Many of you know, we elected we flipped the only Senate seat in the country from red to blue. So we're proud here in Pennsylvania, but I'm the chair of the committee, so I'm going to take prerogative to give my time over to Maureen Mo Brinck-lund. So we have a few minutes for discussion on ERISA, and then there are a few questions we can yank out of the chat. So Mo, can you come up? Thank you.
Thank you, Chuck. Thank you very much. So my name is Maureen Brinck-lund. Everybody calls me Mo for short. And I'm with Healthcare as a Human Right Washington. And I have to say, I'm a relatively new advocate in this space at all. And many of the people I am learning so much from are in this room at this moment. So I guess you can go to the next slide for a little outline. I'll talk more about HCHR a little bit at the end, but I wanted to start by just letting you know about the Universal Healthcare Commission that's been established in Washington State back in 21, and it's met for a full year and going on its second year. Much work was done in Washington State prior to this for years, for 30 years. In the 90s, we had a pretty good start on things, and then the majorities changed over. Between 17 and 19, there were multiple bills with multiple sponsors that, you know, they haven't passed the whole gamut to get through. Then the Universal Healthcare Work Group, which is really an important feature, worked for a year or two, I believe, but they came up with 3 healthcare models, really important to see. And I will put a link to that in the chat. The Universal Healthcare Commission, which is now established, and I, with Healthcare as a Human Right, I've co-chair a subcommittee that is monitoring the commission. So that's kind of my space. I'm more informed on that perhaps than some of this other historical material and legislative material. So the Universal Healthcare Commission published its first report at the end of 22. And in this year, they've created the Financial and Technical Advisory Committee. And we were very proud of that happening. We also we've looked to Oregon's work a lot because they had 3 separate committees, one for the financial, one for technical, and the all-important public outreach, which we have not yet designed into our system. So you can go to the next slide, I think, Barbara. Thank you. So the prior bills there, and there are people in this room who were very involved in these bills. The Washington Health Trust Bill, which the commission has now agreed to review. We're really working on the commission and our subcommittee to review some of these other plans and bills that have existed before, so they can get busy creating a plan, so they can start moving forward with the federal government and other aspects of creating this plan. So both of these plans offer designs that leave space for the federal programs, design a system, and just have space for the federal programs to fill in. So the Universal Healthcare Commission is tasked with starting the waiver process as soon as there's a plan in place. And I should stop here and just say that our Universal Healthcare Commission was created with two goals in mind. One was to create a plan for universal healthcare, and the second was to create transitional steps that would move us, tighten up the system that's here already and move us towards the transition to the universal healthcare. We won't be able to do a universal healthcare plan without further legislative and governor signing off on one. But I don't have my picture of my slides here, so you can go ahead with the other one. Oh, yeah. So on to the advocacy work. Before I get here, let me please tell you that in order for you to find this information and much more, my colleague who has been in this group before, Marcia Stedman, has written up a beautiful piece that's accessible through that wonderful interactive map that Barbara was telling us about. So please understand that you can get all of this and much, much more through that map. I want to encourage you to use that map. And as far as our commission goes, we've been working hard with the commission, and we have had some successes in steering them in the right direction. But one of the things that's really remarkable about Washington State's commission, I think, is the leadership is a woman named Vicki Lowe. And Vicki is, she's the chair of the commission, but she's also the executive director for American Indian Health Commission in Washington State. And in her capacity in that tribe as a leader of the tribal benefits group, they designed a system that is essentially a single payer system. They got all people's different healthcare packages together. People are covered by a lot of different things in the tribe. And then they created a wraparound care so that everybody has basically the same coverage. And if you ask anyone in the tribe who their healthcare coverage is provided by, they will say, "Oh, I'm on the Indian healthcare." So it's like transparent, or not transparent. But it's like people can't see all the little healthcare things that are working for them under this umbrella, and they just know they can get the care they need. And by goodness, it is a very complicated system that Vicki had to work with. So in addition to that, we also have state employees on the commission who are very pro single payer. And we're really excited to have on our commission the head of the Office of Equity, recently formed Office of Equity. And then other members, we have the head of the Somali Healthcare Board on the commission. So we really feel like that has worked to our benefit, to have a diverse community representation on the commission. So in our transitional steps, you can see this through the map, but we've done a number of things in 21, 22, 23. We created a public option. Now that's just like a transitional step in, we secured a 1332 waiver for undocumented immigrants, which is the first in the country. So they'll be able to be covered on a plan through the ACA. They were not ACA eligible, but they'll be able to get coverage through the exchange now. And 2023 budget passed in the House directs the exchange to revisit and figure out a way to draw down federal funds, which is similar to Colorado's, I understand, which included mandatory premium reductions, which ours does not yet. So we've created other boards, the Healthcare Cost Transparency Board, the Total Cost of Insulin Work Group, and the Prescription Drug Affordability Board, all of which are going to work in cooperation with the commission and each other to create more cost containment in our state. So I'm sure I've run over.
We're down to about 5 minutes to the end of the session. And so
sorry about that. I will put a couple of links in the chat, but please use the map to find the rest of the links. Thank you.
Okay, thank you. And let's see how to use this last 5 minutes. I did pull a few questions out of the chat. Some people want to. If you haven't done so, because a lot of people came in after the session started, could you rename yourself so everybody knows where you're from, please? That really is helpful. Your state, maybe your association. I also want to just throw a shout out. Phil Kim with California Nurses NNU is with us. Hey, Phil. I know a few questions came up regarding ERISA. What I think we will do, we will dedicate some concentrated time at OnePayerStates to a dedicated workshop or two and really dig in on ERISA. We can't do it justice here today, in just a few minutes. I mean, it would take a good chunk of time to explain why ERISA is critically important, the Employee Retirement Income Security Act. I also noticed there were questions about how organizations are funding their studies. Folks who have those questions addressed to them can handle that. The Maine being a small state, Lynn, a couple of people asked you, how do you deal with the size issues, the fact that it's a much smaller state? And then I did also want to swing back and really underscore the need that we need help in every congressional district in which you've got reach. We need to get every member of Congress to sign on when the bill drops, when Ro Khanna drops his bill. It's the position of OnePayerStates. I know there's a debate back and forth. Who needs waivers? Do we need waivers? Do we need an ERISA waiver? Have we got a workaround? My position and that of OnePayerStates is I'm an agnostic. We need those waivers. That's what we strive for. We want to get those waivers. It accounts for 50 to 70% of the total funding at the state level. For one thing, the financial waivers and the ERISA waiver. Do we really want to test the Supreme Court? Do we really want to test the Supreme Court and their corporate mentality and not have ERISA waivers? I don't think so. So my position and that of OnePayerStates, our official position, is that we've got to get those waivers. And I'm pushing on Kana to make sure that he makes that his point of emphasis and that his legislation has every opportunity to pass in the year 2025 as we sync up with Oregon and Washington in particular, who are ready to roll out their universal healthcare plans in 2025. We need to coordinate this work. We have to be extremely proactive. And so that's the position that we're taking here at OnePayerStates as the leading organization advocating for the states. We have just a couple minutes here left. Do any of our panelists want to come in and just say anything to the questions that were asked of you real quickly? Lynn, do you have anything to say about how do we deal with the small state issue?
Yeah, well, yes, we are a small state, but Saskatchewan was 1.3 million people and Maine is 1.3 million people. And both the economic studies we did, Mathematica and the Maine Center for Economic Policy, the links are in the chat, show that you can do it and save money. We're continuing, we're going back again and we'll still prove it. But I don't think that the money issue is really, although everybody brings it up, every study has shown that you can do it and save money. So that's where we are. We were fortunate in obtaining grants money for a part of the studies that we've done. And and I would, and it also helps your supporters to go have a data set to go out and talk with. So that's why we're updating our report to go to the stakeholders. You can't just say, trust us. You have to have something current and in front of, to put in front of them.
Okay, thanks. A really good response, Lynn. And we are just about out of time. I'm just going to put out another personal plea to support the work that we do through donations as well as joining the work that we do. I've spent the last 4 months up in the Northwest. I voted with my feet. I live here in Western Pennsylvania, but I went out west, Northwest, to meet with people, to break bread. And then we're going to do a follow-up conference in the middle of the summer. This is really serious work that we're doing. And then we're going to convene state representative or U.S. representatives for the first time, U.S. representatives, and bring them together with state representatives to make sure that we're talking to each other across bands of governance and that folks are actually taking this stuff seriously. We need to model a universal healthcare system in 1, 2, or more states in order to convince the country that this has got to be the direction we go in creating a national single payer system. I'm convinced that this is the pathway forward. And so I'm going to move my way over toward Washington, D.C. I've got housing in rural Maryland, but it's a struggle. I'll be honest with you. It's a material struggle financially. And I don't get paid for this stuff. I'm just looking to get expenses covered. And that's all. And I pour every bit of what I have into this work. Many people, know who I am. I just want to put that forward, that this is the work that we've got to be supporting. I believe that we're on the cusp of a revolution here. We break out on this, and I think all other social justice issues are going to fold in behind us and with us at the same time. So thanks so much, everybody, for being with us today. Deep, deep gratitude, radical hospitality, radical hope, radical love. That's the way we go forward. Thank you, everyone. Welcome, folks, to the State of the States workshop provided to you by the OnePayerStates organization. And we're thrilled to have you with us and to provide updates from several of our states, Colorado, Massachusetts, Maine, Minnesota, New York, Oregon, Pennsylvania, and Washington. And we'll also be covering today, again, ground around Ro Khanna's state-based universal healthcare legislation and dive in a little bit to around the discussion of why we need those waivers, those financing waivers, as well as the ERISA waiver, the Employee Retirement Income Security Act waiver. So let me pull up. So my name is Chuck Pennacchio, and I'm president of OnePayerStates, have been so for the last 5 years, I think. We've been around as an organization, really a structured network of 22 states. Plus, within some states, there are multiple campaigns, parallel single payer campaigns. We want to acknowledge all comers, those folks who work at the focus primarily on the state legislature, those who may be running referenda, and those who work on both. But there's no given pathway to success. We have models, we have history, but we at OnePayerStates, we want to work with everyone who wants to work in pursuit of single payer, whether it be at the national level, the state level, the regional level. So with a 2025 target year of implementing truly comprehensive guaranteed universal healthcare systems in at least 2 states that we can identify, maybe more, with the nation soon to follow, the OnePayerStates network of 22 state campaigns or 22 state campaigns within 22 states is proud to update you on our strategic, state-based trailhead to national universal single payer healthcare. Based on our applied theory of change that learns from the Canadian example, where the province of Saskatchewan led the way to national Medicare for all, our own history, our own American history, United States history of social change as captured in the progressive and New Deal eras, where there was state modeling, which led to national labor, suffrage, and healthcare advances, among others, as well as coalition building based on shared values, intersectional justice issues, and strategic visioning, planning, and execution. We are leading the way on a multi-state, 2-track, state and national campaign for success. Complementing the remarkable progress at the state level is congressional enabling legislation previously carried by Jim McDermott of Seattle, who was succeeded then by Representative Pramila Jayapal, who carried the state-based universal legislation, and now being carried by Representative Ro Khanna. This again is the State-Based Universal Healthcare Act, which we fondly call SBUCHA, S-B-U-H-C-A, SBUCHA. It's the State-Based Universal Healthcare Act of 2023, which will soon be reintroduced and is known as, you can reference that as HR 3775 from the last Congress. And we'll drop links into the chat, or somebody can do that even for us, HR 3775 from the 21-22 Congress. We intend to get this legislation passed in 2025, when we presume when the Democrats take back the U.S. House of Representatives, retain control and expand control in the U.S. Senate, hold on to the White House. Under those circumstances, we pass this bill in 2025, which will provide the enabling waivers to provide as seamless an implementation of state universal healthcare plans as possible. And during the course of this presentation, you'll learn how to support this critical work at both the state and national levels. We also want to make it clear that our gold standard, our North Star, is national Medicare for all. We just go by the belief that given our history, given our constitutional framework, given the resources arrayed against passage right now in Washington, D.C., that the states offer a tremendous opportunity to achieve our goals. And then we'll drop links into the chat for you to learn more about OnePayerStates. Having said that, our strategic work begins with the organizing credo of radical hospitality, radical hope, and radical love, whereby universal transformational justice is not only possible, it is inevitable in our view. And when I say radical hospitality, that means welcoming people without judgment. It means listening intentionally to partners, other folks working in social justice movements across the board. Radical hope, which is to say that hope isn't maybe enough right now. We need to go all in with hope and belief that we can do this, holding that vision of a justice society at the forefront of our thinking, and also radical love, which means doubling down on our empathy and our compassion in the work that we do. So again, welcome to folks who've joined in the last few minutes, if you could, please rename yourselves, indicate where you're from, associations, personal pronouns. At this point, I want to bring up our OnePayerStates state map curator, Barbara Pearson. Barbara? And thank you, everyone. Thank you, the organizers of this event, Ben and Jillian, as well as participants across the board. Thank you all for being with us. Barbara?
Barbara, you're muted.
Need to.
I did unmute. Oh. Yeah, I'm unmuted.
You're good. You're
Got
remuted for
muted
something.
again.
And
Barbara,
then
you
as
oh, there.
I've done that. Okay, well, can you hear me now? I hope. So I wanted to show you my screen, the screen. I had hoped that I could do it live online, but my it's not strong enough, my internet. So this is a map that's at OnePayerStates.org/state. And this is the map part. And it's a dynamic map so that if you hover on one of the states, like here, before I took the snapshot, I hovered on Maine and then Maine came up, I double click, and then I go to a profile on Maine with their activity, their people, their contact people, and so forth. We have, but I'm going to go back to here. But we have this little list of current bills and so forth is not really on the website, but you can tell by which states are lit. And it's about 20. And if anybody is working on a state and I don't have you, or if I have you wrong, please get it back in touch with me. I will put my email in the chat, but you can also get me through OnePayerStates. In addition to the campaigns in California, Maine, Massachusetts, many of us are here. There are also states that have had single payer legislation in the past and are working on getting it again. So, and some of them that are not working on getting it. And we also have some people that are working on regional sorry about that, working on regional efforts. So up in the Pacific Northwest and in New England, especially in New England, where we have these small states, we've been talking about consortia where we can either do something like everybody have a state bill that's reciprocal with the states, with all the other states, or even just do some things like getting together for negotiating drug prices on a larger scale, things like that. We also have states that can use a ballot. That's a constitutional issue within the state. And so there's about 35 states that can do it. We in Massachusetts have been using the non-binding ballot question. We could do a ballot question, but it's a big, expensive proposition. A non-binding ballot campaign is relatively easy, and it makes a great basis for lobbying and bird dogging if you can go to the district rep and say, hey, your district voted in favor. We also have within OnePayerStates, we have people who analyze the bills. So if you have questions about the bills in your states and so forth, we're a good resource for just tweaking your bills and making sure that they have all the characteristics. Anyway, I'm not going to spend too much because I'm going to get to talk about my state soon, and I'll let some other people talk about their states. So let me escape and stopping share.
Terrific, Barbara. Thanks so much. Yeah, thanks so much for the overview on our state campaigns. And we're going to go in alphabetical order by state at this point. So we'll go Colorado, Massachusetts, Maine, Minnesota, New York, Oregon, Pennsylvania, and Washington. So coming up to talk to us from Colorado is Lydia Guzman, Healthcare for All Colorado. Lydia?
Good morning, everyone. Buenos días y bienvenidos. My name is Lydia Guzman, and I'm from Denver, Colorado. I'm president of Healthcare for All Colorado, and I'm on the OnePayerStates board. Before I begin, I just want to tell you that I said I was a retired educator, but one time we invited Rose Roach to Denver to do a presentation for Healthcare for All Colorado, and she really got me very interested in the work, and she made me feel that you didn't have to be a medical professional to be involved at the grassroots level to get it done. I also want to shout out Elaine Brainerd, who has developed a terrific relationship with Representative Basenecker, who is pushing our current bill in Colorado. And want to shout out all the organizations who've been working together to get the work done. We have a lot of shout outs. I don't have a lot of time to shout out everyone, but they're on the slide here because of the time that I have to speak. But I do want to shout out everyone who's been working on our latest Senate bill and House bill, and we're looking to have a ballot measure in 2025 or 2026 after this current bill goes through the legislative process. At this time, I just want to say a little bit about the prior work that's been done in Colorado. In 2019, there was a bill, HB 191176, that created a task force to work with an organization called the Colorado School of Public Health that was selected to conduct an analysis report. And they analyzed 3 different healthcare systems in Colorado, the current system, a multi-system that included employee benefits and private and public funds, and then a third one that looked at publicly financed and privately delivered option that delivered universal coverage. Again, I don't have to tell the activists in the audience that the results presented to the legislature in 2021 found that a fully publicly financed and privately delivered healthcare system that covered everyone in Colorado yielded the most healthcare savings. So that's a significant step. So now we're in the next step. Currently, Representative Basenecker and McCormick and Senator Hawkins Lewis have brought a new bill forth that is House Bill 23-1209 that has passed the House. The total House has gone through a subcommittee in appropriations. It's now gone to a subcommittee in the Senate, which will be having a hearing on this bill next Thursday. So we're thrilled and excited in Colorado about the progress that's being done at the state level. And this would conduct a detailed analysis of the feasibility of creating a publicly financed, privately delivered universal healthcare system in Colorado, including how to finance a system. And it also asks answers some questions. And one of those questions looks at how a system that's a single payer system could look at gaps in the current healthcare system and address those gaps. So I'm not going to go into more detail about it because I have very limited time. I will put some links in the chat, but I do want to say that we have been working at the grassroots level for a long time for this. And I want to shout out the Colorado Foundation for Universal Healthcare, Healthcare for All Colorado Advocacy, Healthcare for All Colorado Foundation Board, Colorado PNHP, Young Invincibles, and all of the work that's been done to collaborate and work on this. And it's just a first step. Like I said, the second step would be a ballot measure in 2025 or 2026. And we currently have 27 organizations on board who are supporting the work and the bill. And we're thrilled and excited by everyone who's come together to work on this. We also I need to say that we are looking for help with the waivers. We are looking at how can we get those waivers here in Colorado. And I firmly believe that we should be working together. And if other states can show us information, OnePayerStates can help us along the way to work and navigate the waiver system. It'll push us further along. Thank you.
Terrific. Wonderful, Lydia. Thanks so much for that. And again, just to remind folks, feel free to use the chat for questions you might have. And if you've not already done so, if you could just rename yourself so we know where you're from. Personal pronouns are also helpful. Yeah, so let's bring up Barbara Pearson again, putting your other hat on as a representative for Massachusetts. Barbara? You got muted again. Let's see. Oh, you're still muted. Something funky with your computer, maybe?
Right now I said unmute, right?
You're good.
Am I
You're
mute?
good. Roll.
Okay, so I'm representing Massachusetts, where we've had a bill in the legislature since the 90s. Each time, we currently have two bills, one in the House and the Senate, that were introduced again. And these are bills that just keep getting better and better. They guarantee equitable health care for every resident. It provides healthcare services that are continuous without the need for current repeat re-enrollments, changes when employees and stuff like that. Comprehensive with no cost sharing at the time of service, although with a progressive financing system. We have a super majority of Democrats. Last time we had 82 out of our 200 representatives and senators that were co-sponsors of the bill. This year, we're going for over 100. So far, we have 46 in the state. Come on. We have a coalition of over 80 member organizations that represent very diverse constituencies. And so together they represent over 500,000 supporters. As I mentioned, we used this non-binding ballot question in 20 districts last time. And instead of needing thousands and thousands of signatures, you just need about 200 or 300. And then you have this really good tool for educating both the people that you're getting to sign on, but also your legislator. Yeah. And then we also have, as you know, in Western Mass, we seem to have a lot of the healthcare economists. So Jerry Friedman is an Amherst, and he's done the financial analysis. He did it for 21, and then he's just updated it for 23, and that's available on our website. You can either get the summary or the full thing, and also Jerry's very effective testimony before the joint committee, the healthcare committee. So we like every state, doing it on the grassroots, doing it in the legislature, and we also have to work not just on our own reps, but of course it's the leadership in the House and Senate. So I think we go to Minnesota, Maine, and she doesn't have, so I'm going to try and escape.
Great,
and
thanks,
stop
Barbara.
sharing.
Yep, we'll bring up now Lynn Cheney, and I just want to grab a comment that was made earlier by Lydia, that this is a very diverse panel we have here. The only actual medical professional retired is Ann Jones, but everybody else has a unique set of backgrounds. So Lydia comes out of education, Barbara out of academia, higher ed, Morgan, fine arts, but introduce yourself, and Lynn, your background's in business. So this is the kind of diverse representation and coalition building in person right here. That is the kind of work that is really necessary to get this work done. So I just want to give that acknowledgement that we are very diverse right here in this space. Lynn, thank you.
Yes, and Chuck, you're right. I mean, I ran a small business, small manufacturing company for over 30 years. And I was acutely aware of the difficulty and the cost of negotiating health insurance for my employees. It got worse and worse every year. In retirement, I served 9 years as an ACA navigator in Maine, talked with hundreds of individuals and businesses. And I was just, I'm so angry about how complex the system is. And increasingly, the co-pays, deductibles are increasing the out-of-pocket costs, and many of the people become underinsured. So in any case, that drove me to Maine All Care, and I serve on the board of Maine All Care. We're a nonprofit that was formed in 2010, and we're the only entity in the state established for the sole purpose of promoting publicly funded healthcare for all Maine residents. There have been efforts over the past 20 years to implement state-based universal healthcare in Maine, and these include two major fiscal studies that show that such a system would be economically feasible. And we came close to having a single payer bill in 2014, which was passed by a significant margin in the legislature, but vetoed by then Governor Paul LePage and came up 4 votes shy in the override. In 2020, we formed an advocacy arm to mount a ballot initiative, but the effort was halted, and that was largely due to the difficulty of gathering enough signatures in the time of COVID. In 2021, a comprehensive healthcare bill, vigorously supported by Maine All Care, was drastically amended at the suggestion of the smart, politically savvy chair of the Legislative Review Committee, and was voted out of the committee as ought to pass. The amended bill is short and sweet. It creates the Maine healthcare plan to provide all medically necessary healthcare to all residents in the state, and forms a board, significantly with no insurance representative, to oversee the planning, implementation, and administration of the plan. This bill was passed by a majority of both the House and Senate and became law without the governor's signature. But, and this is a big but, this bill may not be implemented until the state obtains a waiver for a state-based universal health care plan and receives federal financing to support the implementation of the plan. California Representative Ro Khanna's SBUCHA bill, which Chuck alluded to or talked about earlier, and we can talk about it more afterwards, is the intended enabling legislation. And this means that Maine is in a unique position to have a universal health care bill that is triggered by SBUCHA. In the same session, the Maine legislature passed a joint resolution calling on the president and Congress to establish a federal waiver process for states in order to enable state-based universal health care plans. It specifically calls out the SBUCHA bill, and I would suggest that other states consider asking their legislature to do the same thing. I'll put a link to that, the wording of that resolution, joint resolution, in the chat, and maybe you can work on it. We also have a constitutional amendment that is in process that establishes the right to health care in Maine, and it's before the current legislative session. A hearing is yet to be scheduled, and this will require a 2/3 vote in both chambers. Maine All Care will testify in favor of the bill. And finally, Maine All Care recently contracted with the Maine Center for Economic Policy to update a 2018 fiscal study, and we'll be using this information to draft a plan with input from stakeholders, and with the hope of submitting a comprehensive bill in the 2025 Maine legislative session. So thank you. I'll put links in the chat, and we'll go on to the next state.
Terrific, Lynn. Thanks so much. Next up, we have Ann Jones from Minnesota, Healthcare for All, Minnesota. Ann, thank you. You need to unmute, I think.
Okay, all steps go. Hi,
You got it.
so Ann Jones, as Chuck said, retired RN and Vice Chair of Healthcare for All Minnesota. We're working, like everybody else, on a state-based plan for Minnesota, and actively supporting a national health plan, Medicare for All. We partner closely with Physicians for a National Health Program, the Minnesota chapter, and the Minnesota Nurses Association. We reconstituted in late 2016 with a new board and a new approach, organizing and building our base and educating the public by getting out to events with speakers and informational tables. Getting out to rural Minnesota is a challenge for us. And in 2022, after 10 years of divided government, the Democratic Farmer Labor Party took a majority, held on to the majority in the state house and captured a 1-seat majority in the state Senate for the first time in 10 years. This offers some opportunities, but we're also competing with other progressive organizations with their legislative priorities, which have been on hold for some time. We are fortunate to have a longtime champion in the state Senate for a publicly financed and administered universal system. The legislation is written, it's excellent. It was reintroduced this session with a lead sponsor on the House and Senate sides and good support from legislators, all DFL as expected. New for us as an organization was to take the step of crafting a statement of legislative priorities and sending them to the Speaker of the House, the Senate Majority Leader, and the chairs of the Health and Human Services Policy and Finance Committees prior to the start of the session. We've been connecting with the committee chairs as well as leaders in other advocacy and issues organizations to support legislation that represents steps toward real progress rather than the incrementalism that seems to plague this movement. Incrementalism, the tendency toward what's politically feasible rather than real reform is a barrier, I guess, in my opinion. Minnesota has had a basic health plan for lower income working people called Minnesota Care that was supposed to be the precursor to a single payer system for our state. That bill passed in 1992, over 30 years ago, and no real progress has been made since. We were allowed to keep Minnesota Care as a basic health plan under the ACA, and the DFL majority legislature at that time, 10 years ago, improved the coverage under that plan, as well as setting up the insurance exchange, which is called MNsure in Minnesota. Yet because of eligibility rules, we have under 90,000 enrolled in this at this time, with a population in our state of 5.7 million, and then 1 in 5 persons relies on Medicare or medical assistance, it's called in Minnesota. So our board and our coalition building committee agreed this year on a set of principles for evaluating and supporting legislative proposals that we consider to be building blocks toward the goal of a state-based universal health plan. The emphasis here is on measures that would help build the infrastructure for a publicly funded and administered system, starting with deprivatizing our public programs, making current coverage more affordable, increasing the number of people covered, adding cost containment provisions, and adding undocumented persons to Minnesota Care. With these principles in mind, these are the bills we're supporting this session, and our top priority is getting that analysis of the costs and benefits of a universal healthcare system passed with funding allocated. It looks like that's going to end up in what's called an omnibus bill at the end of the session, but should pass. The previous study is now 10 years old, so we needed to repeat it. The bill attracting the most attention from our DFL legislators and progressive advocacy groups is a proposal to expand that basic health plan I talked about, Minnesota Care. It was crafted now as a Minnesota Care public option. The rationale for this proposal tends toward the politically feasible argument, a belief that it could be implemented more quickly and that it would be a step toward the single payer solution that we really want. Most people listening today know the pitfalls at the state and federal levels of public option proposals, and there are a number of them. While this bill as written has some positives, we have concerns, and we're trying to communicate those to the sponsors and the supporters of the bill without alienating current and future partners for reform. An amendment to the Senate version just appeared with a complicated enrollment and performance measurement and reporting requirements added to the original proposal. So as we work to get hearings and move forward with real reform, we're building political power by inviting like-minded organizations to join with us in a coalition to craft a real campaign for a bill to pass and implement the Minnesota Health Plan. We're also showing up or going on the record in support of legislation important to our partner organizations, such as the Paid Family and Medical Leave Act, championed by small business and others, the gun violence prevention bills, the bill to address environmental justice, and others. Our new board chair, Rose Roach, known to many or most of you, is also the national director for the labor campaign for single payer. So of course that helps us with our work to build up our relationships with organized labor in Minnesota. We've also invested time and resources in educating the public that privatizing and monetizing Medicare via Medicare Advantage and ACO REACH schemes are serious threats to the financial stability of our public insurance plan for seniors and the disabled, and a threat to our work to achieve publicly financed and administered Medicare for all. And my closing thought Since I'm newer to this movement, I spent 5 years as a volunteer and now have been 5 years really actively immersed in the work of Healthcare for All Minnesota. And I've talked to thousands of people in our state and leaders of other organizations. It's far too easy to default to what's politically feasible. And it wastes time and political capital, giving you the illusion of progress. We know we need a strategy to win, the tactics to support the strategy, but we also really need a sense of moral outrage at the greed embedded in our current system and the indifference of the haves that is sufficient to get the public to demand change and vote their interests. So that might be our biggest challenge at this time. I did put the address of our organization in the chat, and thank you for your attention.
Great. Thanks, Ann. Appreciate that. Just wanted to, there are a handful of folks with us. You probably came in later. If you could rename yourselves. I've got Arthur, Greg Miller's one of our, is in Ro Khanna's district and is on our working group with the state-based universal healthcare. Welcome, Greg. Judith, Levon, Maddie, Marva, Peter, Pam. If you could just indicate your state, that would be helpful. We'd just like to know who all's with us, so that we can, appropriately address our comments and everybody knows who's who. So next up we have, and Phil Kim's with us again from the nurses. Thanks, Phil, for joining us again. Morgan Moore from New York is going to be addressing what's happening there. Morgan is with PNHP New York Metro Chapter. Morgan, thank you.
Great. Thank you, Chuck. Good afternoon, everyone. My name is Morgan Moore, as Chuck said, and I use she, her pronouns. I'm the executive director of the New York Metro Chapter of Physicians for National Health Program, and I sit on the steering committee of the Campaign for New York Health. We employ many different strategies and tactics in our organizing for the New York Health Act, which is our state-based bill, and far too many for me to cover here today. So while I talk, I wanted to share a few images from various events, actions, and initiatives as examples of the work we've been doing and as inspiration for future organizing. As some of you might likely know, our state single payer bill, the New York Health Act, was first introduced 32 years ago in 1991 after nurses with the New York State Nurses Association Union persuaded Assemblymember Dick Gottfried, the author, to author and sponsor the bill. The New York Health Act has passed the Assembly 5 times and most recently in 2018, but it has yet to be brought to the floor for a vote in the state Senate, despite the fact that a few years ago we achieved Democratic supermajorities and have a majority support for the bill in both chambers. In 2019, the New York Health Act was amended to include long-term care, which was the result of collaboration with disability rights and senior advocacy groups. The inclusion of long-term care, abortion and fertility care, dental and mental care, gender-affirming care, and covering all residents regardless of citizenship, employment, or other statuses makes the New York Health Act unrivaled in terms of comprehensive coverage. No other existing proposals, programs, or plans, including union plans in New York, can compete. The incredible progress that we've made on the bill in the last several years is due to strong grassroots organizing across the state, facilitated through the leadership of the Campaign for New York Health, through a distributed organizing model that empowers organizations and activists to organize around the bill in the ways that best suit them locally. Throughout our organizing, we've focused on using the power of our stories to move people at their emotional core, to demonstrate the deep need for systemic change, and to illustrate the connection between the fight for single payer and the countless other fights for racial and economic justice and human rights more broadly. We've focused in particular on supporting and uplifting the experiences of marginalized people and communities who are disproportionately harmed by our profit-driven racist healthcare system. As you can see in this slide, our media strategy also pulls from the power of our stories and the intersections of related struggles for justice. I'll share some links in the chat for some of the press that's shown here, and for our chapter's MedStory Monday social media campaign, as well as some other inspiring organizing that's happening throughout the state. This past year has been a transitional year for us in both the campaign and in Albany. Senator Gustavo Rivera remains our steadfast lead sponsor in the state Senate, but Assemblymember Dick Gottfried, author of the bill and lead sponsor in the Assembly, retired this past December. and Assemblymember Amy Paulin has replaced him as both Health Committee Chair in the Assembly and the sponsor of the New York Health Act in the Assembly. It's our understanding that Rivera and Paulin will be making some amendments to the bill, primarily to address specific union concerns before reintroduction this session, once the state budget is finalized. Unfortunately, the state budget is now 3 weeks overdue, and it's holding up all other matters until those negotiations conclude. So last but not least, in some very exciting news this month, the Campaign for New York Health hired a new executive director. So please keep an eye out from the campaign for a big announcement about that. The best way to learn about the bill and to keep up with the campaign is by signing up for the campaign's mailing list on their website, which is shown on your screen here. And I'll drop a link to that in the chat as well, and to some other information. And thanks very much. I'll hand it back over to Chuck.
Thanks so much, Morgan. Exciting work happening at so many different states. Thanks for New York. Next up, we have Linda Krieger out of Oregon, and Mid-Valley is advocates for healthcare justice and healthcare for all Oregon. Linda, thank you.
Hi, Chuck. Thanks. Yes, my name is Linda Krieger. My preferred pronouns are she, her, and I'm a member of the Mid-Valley Healthcare Advocates. And this is a group that I've joined more recently, but that has been working toward single payer universal healthcare in Oregon for over 30 years. So a lot of work has gone on in the past. And I just want to give a shout out to the folks who've been involved in that over the years. Over the last year, we have had some significant milestones that we've met in Oregon. And so I want to really highlight those and talk about where we're going next. In September of last year, of 2022, our Joint Task Force on Universal Healthcare, which was created by a Senate Bill 770 that was passed in 2019. So after several years of work, they did present their report to our legislature here in Oregon. And that report detailed benefits and cost savings of a single payer universal health plan in Oregon. It's very comprehensive. That task force did amazing work and really put together something that our legislatures and our public could wrap their heads around, hopefully, about why this is so important and how it addresses many of the concerns that our folks have about their health care. Another thing that happened last year in November is we did pass Measure 111, which created an amendment to our state constitution that guarantees access to affordable health care as a fundamental right in Oregon. And that is a real milestone in giving the message to our legislatures and that the people of Oregon think this is a fundamental right and that it should be at the top of their lists. More recently, in 2023, this year's legislature, there was introduced a bill, Senate Bill 1089, that was based on the task force's recommendations. And that establishes a universal health plan governance board for the state of Oregon. And this is intended to be the permanent board as we actually get to the implementation of universal health care in Oregon. So it's a very exciting time right now. That just passed out of our Rules Committee last Thursday and is headed for the Ways and Means Committee. We have many sponsors and many supporters. We have grassroots folks who have been giving testimony to our work groups and legislatures and really promoting this bill so that we can take the next steps in implementing universal health care in Oregon. So really excited to see what happens next. And I will put some links to each of these things so that you can see in the chat so that you can get more information about how we've done what we've done and the actual language of some of this legislation that's been approved here in Oregon.
Terrific, Linda. Thank you so much for that report from Oregon. Very exciting steps moving forward. I'm going to just say a couple things on behalf of Pennsylvania, and then bring up Maureen to talk about Washington. But here in Pennsylvania, the political dynamics have changed for the first time in many, many years. So more than 10 years, the state house has flipped to the Democrats, and that came in surprising fashion. So we have real opportunities to push out on our single payer bills, which have already been drafted. And by the way, the title that we use, I hope people will take note of this. It's the Family and Business Health Security Act. The Family and Business Health Security Act. And I just wanted to say that by checking all these boxes, Family and Business Health Security Act, it opened more doors to more Republicans when I was lobbying in Harrisburg than you might imagine. It really does. It really is a very inviting way to have this conversation with people who identify in the center right, Family and Business Health Security Act. Just consider that for your own purposes of how you go forward, because framing means so much. Labeling, framing, branding. In any case, I learned that we were able to, because of that, and our sheer persistence, we had the only Republican-chaired standing committee hearing on single payer, I believe, in our country's history. That happened back in 2009, December of 2009, before Obamacare came in, the Affordable Care Act. But I'll tell you, and the guy who gave us the hearing was an insurance industry life executive. He was a lifetime executive. And we broke down the walls because of sheer persistence and our ability to frame the issue and talk about it in different ways. So we're going to take another charge at this. Here we are, another more than 10 years later, but things are looking promising in Pennsylvania. So I just wanted to share that with you. And that's all I'm going to say about Pennsylvania right now, other than we did flip the only US Senate seat in the country from R to D. And the first time in decades that we went from a Democratic governor to another Democratic governor. It's always gone Democrat, Republican, usually 8-year segments. So things are really hopping on the ground here. We're really very proud of what's happening in Pennsylvania. With that being said, let me turn it over to Maureen Brinck-lund. Do you want to talk about Washington? Thank you.
Thank you, Chuck. And thank you for that, that bill name. That is awesome. Family and Business. It appeals to so many. So anyway, this is my little introductory slide. I have a few slides. The path to universal health care. Impossible to cover everything. And there's already been so much information. I just want to say my learning sort of in the last 48 hours or so is the power of us all. We're in, just like with the virus, we're all in this together. And I want to thank OnePayerStates for making it possible for us to come together and have a way to be in unity around this hard work that we're all doing. This is the Universal Healthcare Commission. I didn't write it out fully, but this is a little bit of a history. Before in Washington State, Chuck asked us to introduce ourselves a little bit. So I'm one of those people who, excuse me, I'm not a healthcare person per se. I have what's called a portfolio career. The last thing I did was career outplacement services for people who had lost their jobs, career counseling essentially. And prior to that, I was a landlady for 34 years. I took a break to get a master's in counseling. And I worked with a research project with some nurses on Alzheimer's and sleep for a while. And prior to that, I was a tech writer for many years on a consulting basis. So I was sort of part of the initial gig workers back in the day. And I think the thing they all have in common is that I love to talk to strangers. So that's helped me be a willing doorbeller as well. So that's who I am. And I've come to this really through COVID because of Zoom, we were all able to meet, and I got hooked up with healthcare as a human right. And now I co-chair the committee that follows this Universal Healthcare Commission. So that's mostly what I have to speak about, but I gathered some other information. But I'd like to leave time for the Q&A. So I'm going to run through this real quickly and just say the Universal Healthcare Work Group there at 2020, that group met and they did work of defining universal healthcare, and they also created 3 models. So and the one that was publicly managed and publicly funded and governed saved billions of dollars, literally, just in the state of Washington. So for all of you listening, I want you to know that OnePayerStates map is where you can find all of this information and more, plus the hot links to the bills and the groups. So I would suggest that you just put that down and sit back and relax because you can get this information elsewise. You don't have to look in the chat. You don't have to write it down on paper. The Universal Healthcare Commission was formed in Washington State, met for a full year, put out a report. And in the law that created that commission, there were 2 mandates. One was to create some steps along the way that create and implement immediate and impactful changes in the healthcare access and delivery system in Washington State. And some of those things are actually coming about. And some of them are through the commission, some elsewise. I'm still back on that first slide, sorry. And the second thing was to prepare the state for this universal healthcare system, including a unified system. And they were to look into single payer as well as other methods. We're having a job keeping them aware of single payer being an issue that they need to be dealing with. So in 2023, as you can see there at the bottom, the Financial and Technical Advisory Committee has come about, and that is very timely and interesting. We are learning a lot from Oregon, and we're collaborating with Oregon. People are coming to our meetings and helping us and advising us. So that's another instance where coming together, and there's even talk about regional solutions. I guess you can go to the next slide, Barbara. So this slide is just listing a couple of bills that went before. We're trying to get the Universal Healthcare Commission to look at these existing bills, because those could easily be the program for a new bill. And but the big problem, of course, is the federal stuff. And in SBUCHA lies a lot of our solution to that. So our commission is tasked with starting the process of getting waivers as soon as there's a plan. There just isn't a plan yet. So the next slide shows a few of the hotspots of transitional strategies. There's a public option that's been added to our availability in the state, but which was, I guess, the nation's first. And the 1332 waiver for undocumented immigrants is the nation's first, and we were able to pull that off this year. And then that waiver is going to be looked at again to see about creating premium reductions, much as Colorado has done. We've got 3 new groups in the state healthcare bureaucracy that is working on cost transparency and cost control. So I think you can go to the next slide, because before I stop talking, I want to brag on Healthcare is a Human Right Washington. What a fantastic group. We're a coalition of 66 other groups, part of Washington Community Action Network. All these links and everything will be in our page on the map. So this HUC subcommittee is the one that's tracking, monitoring, and trying to influence the Universal Healthcare Commission. And we've had some great successes, I think, but they come in little incremental pieces. And yesterday I spoke about the head of our Universal Healthcare Commission, who is Vicki Lowe, and she's also the head of the executive director for American Indian Health Commission, which is a nonprofit here in the state of Washington that does Indian healthcare. And in her tribe, she, for 20 years, worked on unifying their healthcare system, and it's been very successful, and it looks like a single payer system. And so it's really great to have her at the top of the commission, and just her style of leadership is wonderful. Some of the things that we're looking forward to doing more of is David Loud is in the audience here today, I think, and he's been working really hard on getting us to coordinate with labor. Washington State Labor is taking a real interest in a single payer universal healthcare system. So I'll leave it at that and turn it over to the Q&A. Thank you.
Great, thanks so much for that, Mo. Appreciate it. And at this point, let's pivot and Well, I want to just set up this discussion around ERISA and SBUCHA, the state-based universal healthcare legislation, and see if folks have questions and concerns about that. We have about 20 minutes remaining. I did see a number of questions. Let me just see if I can fly by them real quickly and then bring this other stuff up. One of the things that we need to talk about is actually getting a single payer desk office, a dedicated desk in Washington, D.C. There has never been one. So we need to pull resources together so we have a dedicated desk. We have friends, Social Security Works, Public Citizen, National Nurses, but a dedicated desk for single payer work in Washington, D.C. to give us pivoting power at the national, regional, and state level. So that's one thing that was asked on a separate question directly to me. We also need to put a legal team together. We need to put lawyers together to examine a lot of these questions, frankly. We need to get lawyers. And I've been talking to Joel Siegel. Many of you know Joel was with John Conyers for years. He's now working on housing issues. But we do need to get a legal team together so we know exactly what we're talking about. People who are specialists in ERISA. So I'm not a lawyer. I don't even play one on television. And then there's another tricky question here. And I know, Phil Kim is with us, and it has to do with how do you pursue the waivers? So this will pivot into the conversation we're going to have right now, which is we do need the waivers in our judgment. That's our view at OnePayerStates. You need that insulation, you need that protection, you need that legal standing, because there are going to be legal challenges. And do we really want this question to go before the Supreme Court? I don't think so. So that's the premise in part of why it is that we support both the financial waivers as well as the legal waiver, which is the Employee Retirement Income Security Act. I'm going to throw a couple things up on the screen here in a second, but the question is, can you begin pursuing the waivers, or can you begin negotiating for the waivers, or can you begin even having conversations about the waivers even before your bill is complete? And there is a back and forth going on in California. I think a lot of people are aware that this is happening. And I know that Ash Kara, before he introduced AB 1400 last session, he did, as I understand it, he went to Toronto, he went to New York, he went to Washington to begin having conversations with folks over at Health and Human Services. And I think that they were simply informational to see what needs to be included in legislation going forward. So I'm just going to say that as an agnostic, somebody who loves to collect evidence and information, I like collecting information. I like to know what different agencies of government, it's not just Health and Human Services. We're also talking about Department of Labor. We're also talking about the IRS, because I believe, and I just had a meeting with Warren George out of Oregon, along with Emma Preston, who is Ro Khanna's Healthcare LA, the question of, do we need IRS waivers? Because it's going to take a lot of creative financing and taxation at the state level. And it's going to require, I believe, waivers from the federal government in order to be able to sort of wrangle these creative financing, taxation financing questions without getting into the weeds or too deeply here. So the question of waivers it's a process question, it's a legal question, it's a procedural question, it's also a political question. And so here at OnePayerStates, we want to be supportive of efforts to get as much information as possible as we move forward so that our legislation is informed as much as possible by what we know, what we can know, and what we can make legal determinations about. I hope that helps to answer the question. It's a sort of a more nuanced kind of a position, and we're not in any way, like trying to insert ourselves into what's happening in California right now. But I just want you to know the opinion from the outside of OnePayerStates, looking at all the states, because Oregon and Washington right now, in my judgment, and I think the judgment of most of us, are closer than anybody else to achieving this. We may have differences here. You never know. California can jump to the front of the queue. New York can jump to the front of the queue if there's a quick political change and shift, and we just never know. But right now, I've spent the last 4 months up in the Northwest having conversations, building relationships, connecting with people, and we're going to be doing a follow-up in mid-July. We're going to be doing a conference to share best practices across the border, Oregon and Washington. And then in August, we're going to assemble, and we're in the process of doing this right now, key members of Congress, including Ro Khanna, Pramila Jayapal, and others with state legislators, to have the conversation across the governing agencies and the state and national representatives. So we need to be talking to each other. I think conversation and communication is critical. And not only is it critical there, but it's critical here. I think we often falter because we're not communicating among ourselves here. And that's really, really important. So I'm going to be more proactive than I've ever been before. So, I'm going to hold myself up to the mirror first. We need to model the kind of behavior we want. And frankly, that's central to our strategy, is being able to communicate. But just thinking in terms of strategy, and then I'm going to come back around to ERISA and SBUCHA. It begins with, in my view, with a visioning exercise. You have to envision the society that you aspire to, the society you want. And this needs to be at the forefront of your thinking. Too many of us get sidetracked. We go into holes. We're pulled into negativity. It's terrible what's happening in our news media, social media, and so forth. So I wake up every day with the vision that we're going to have a better society tomorrow. And that allows me to hop out of bed with more energy and punching above my weight every day. So strategy begins with visioning. And the next thing we have to talk about, again, is communication, self-awareness, other awareness, defining our terms, figuring out who we are, figuring out what makes us work. Are we big enough? How are we going to create size? We need to build coalitions. And that means moving into every other social justice space. And that means you don't have to work in every space, but you have to embrace the sort of the equal validity and of everybody working on housing or climate or education or policing. We've got to see ourselves in co-equal terms. And I think then we can move forward together with a mindset toward justice for all. So it's not just healthcare justice, it's health justice. And that's the vision at OnePayerStates, connecting health and healthcare. So I just want to frame that out as a context for really understanding the work that we're doing and the work that you'd be supporting if you do jump in and volunteer and or contribute. Whatever you do, we want to work with all the other organizations, PNHP, Healthcare Now, Labor for Single Payer, all the state organizations, National Nurses Union, and the other groups that I mentioned, such as Social Security Works and Public Citizen. And of course, you begin naming them and you're going to forget people. But one of the groups that's coming in to join the fight here actually is Adi Barkan's Be a Hero. And they've got a lot of resources. So things are getting a lot more positive in my view, having spent so much time up in the Northwest. So let me pull up for you on the screen here, just for conversation purposes, where we are in terms of the state-based universal healthcare legislation and what that needs to look like. So this is a summary sheet that I'm pulling up. And credit goes to our working team, Sam Metz, PNHP Oregon, Chris, let's see, Charlie Swanson had a hand in this, Chris Curry, and others. So this is a document that speaks to why we need these waivers. So this is it's a just over one page talking sheet. We're going to put this in the form of a brochure, so that we're going to be able to have this accessible for purposes of lobbying. And frankly, we're going to dumb down the language a little bit. We don't want it to sound too wonky. We want it to be accessible. We want the document itself to be attractive and so forth. But these are some of the key talking points. We all know what the value of single payer is as a financing format. Single payer references financing. We also need to be aware that 95% of the public are confused when they hear the term single payer. This is an inside term. It's a term that we get and understand that we're talking about the whole of the project, which is also delivery. But we've got to figure out ways to convey that it's both financing and delivery of healthcare that we aspire to, whether we call it expanded and improved healthcare for Medicare for all, or universal, guaranteed, comprehensive healthcare for all, what have you. But nonetheless, we have to be really smart about our language here. So we know that the amount of money that we save on administration is absolutely critical. And unless you do that, we're never going to be able to get to universal health care. So the administrative piece of it is absolutely crucial. And all credit to the organizations like PNHP and others who have done the research on this work over the years. We've got to figure out the financing piece, right? So and in order to do that, we need to get the waivers to be able to capture the federal dollars we're paying from the states and bring back Medicare, Medicaid, VA, CHIPS, And all these, well, not VA, there's a carve out for VA and American Indian Health Services. But let me just keep going down this list here. Why don't states take the lead? Actually, the states are taking the lead. That's sort of a teasing question. And this is what the work that's been reported on today and yesterday. So these are the federal programs that we need to coordinate in terms of the state-based single payer, and that is Medicaid, Medicare, whoops. We also need a waiver for the Affordable Care Act. We need a waiver here specifically for ERISA. And we'll talk about that in a little bit more depth. I just want to go through the run of what we're after. Federal employee health care plans, TRICARE, and then what I mentioned here, the conversation that we're now striking up with congressional leaders. We want this language in the new state-based universal healthcare bill, and that is a waiver from the IRS. These are all critical components in order to be able to finance as efficiently and effectively as possible to create a seamless, as close to a single payer system at the state level as possible, as humanly possible. Again, there's a carve out for VA, but the VA system remains intact and Indian Health Services remain intact. But of course, at the state level, the program will wrap around any shortages or any shortcomings that might exist with VA and Indian Health Services. So these are the waivers that we're talking about needing to acquire from Congress, and we need all members of Congress, especially in the Democratic caucus. But we also are going to work hard at winning over Republicans who know that their party is a hot mess, and those who are thoughtful and know that they have to figure out a way forward into the future. One of whom is Brian Fitzpatrick, Congressman from Bucks County, where I used to live. I'm going to take a run at him. We're going to work on this. Ro Khan has got a relationship with him. We are going to do whatever we can, not whatever we can in terms of our principles, but whatever it is that we can to win them over. And that includes reframing the way that we talk about these things. Who cares what the language is ultimately, so long as it's successful in winning the fight. So that's in summary what we're talking about with the waivers. Let's talk specifically about ERISA, and then we'll open this up for questions, comments that folks have got. And I know we've got people in the room here smarter than me on ERISA, but ERISA, for those of you who are not acquainted, was a federal law passed in 1974, and it was designed to protect companies, businesses that provided benefits for their employees, including health self-insurance, health insurance. Back in 1974, health insurance was not nearly as big a deal as it is today. Now it's overwhelming in terms of its rank of benefits that come through employment. As you all know, coming out of World War II, the United States made this critical, I think we all believe, for those who support the work we're doing, critical mistake of tying healthcare to employment. Nonetheless, that's where we are right now. And there are a lot of big employers who actually like the healthcare system that we have right now because it gives them a competitive advantage over smaller companies in the same competitive markets, right? The large employers want to hold on to the existing system as broken as it is because it gives them a competitive advantage. And the chances are is that they're going to take our states to court to try to block the implementation of a comprehensive healthcare system. So we need to get this ERISA waiver done. In order to protect the states and to keep us from having to fight the legal battle to implement this comprehensive universal healthcare system. So I'll stop there without getting too far into the weeds and see if folks have got questions, but ERISA we believe it's a critical component, especially from the perspective of the folks in Washington and Oregon with whom I'm working closest these days. But I believe every state really should take a hard look at the importance of getting this ERISA waiver. Because the last thing you want to do is be stuck in the courts, and the last thing you want to do is have your program come before the right-wing Supreme Court. The Federalist Society trained, excuse my French here, fascist Supreme Court, state corporatist Supreme Court. That's what we have to understand that we're dealing with right now. The court system is really tangled, and we need to make sure that we have that insulation. I will stop right there and see if folks have questions, or you want to drop them in the chat. I don't know if folks can unmute, but I guess I think that's basically the gist of what it is that we wanted to cover. Maybe does anybody have any questions or comments? You could just throw up your hand even. Is anything unclear about the general thrust of why we need ERISA, why we need the federal waivers, which account for about 50 to 70% of the funding, 50 to 70% of the funding at the state level? That's why we really want to make sure that we get that, because we need that administrative efficiency. Every payer line that you add to your system it increases the cost of your overall system by 2 to 3%. Every time you add a new line of payer, it adds some 2 to 3%. Two hands are raised. Let's see. Catherine and Bill Davis. So can you, if you can make a really short, we're down to about 5 minutes. Catherine and Bill. Catherine first. Quick question.
Well, I don't have a question. I was, on one of the earlier things during the week, there was even another organization though that talked about, we really don't have to worry about ERISA so much. We just need to create a program that goes around ERISA, allows those businesses to go ahead and continue doing business with the for-profit insurance companies if they choose to, and making the public system more affordable and more attractive to them.
Yep. All right. Well, we respectfully disagree for the reasons I laid out. Thank you. Appreciate it. Bill, and then Lou.
Okay.
Well, I kind of see what you're saying about the different federal waivers needed. I guess the hazard is with all the different differences in state laws, it might be hard to craft something that's going to work for everybody. But I suppose that would certainly be the goal. And I agree with you. We need to pave the way, because if state groups go to all the trouble of getting a law passed and then we can't get the waivers, it seems like that wouldn't be a good thing.
Mm-hmm. Yeah,
So,
thanks
thanks a
for
lot.
that, Bill. Yep, you bet. Lou, unmute. Welcome, Lou.
Yeah, thank you.
Sure.
I agree with Catherine. Our task force in Oregon did this, approached the ERISA subject. Now, we need waivers for federal funds, right, out of Medicare, Medicaid, and CHIP, right? But the task force said, look, we're going to put in a payroll system by which companies are going to have to put out of their payroll so much goes to healthcare program, and the companies can keep their insurance if they want. So it doesn't force them to give up their benefit plans at all. So, we need to take, and that came out of the task force for universal healthcare in Oregon.
I talked to one of those task force members twice a week or more, Warren George. Yeah. You probably know Warren. And I mean, as he explains it, sure, you can keep it all you want, but you're going to have to pay your fair share regardless. So what's the incentive for hanging on to something that's already that's going to be redundant? So sure, I guess you can think of that as an ERISA workaround technically, and I guess you can pursue that through the IRS waivers, which is one of the things that we're discussing now, right? Warren and I are discussing with members of Congress, but that may be a creative way of doing it. I'm not going to, but nonetheless, we want to make sure that we've got as many of these waivers as absolutely possible to give us that insulation, because that's going to be challenged up the court system, Lou. And if we have Congress signing off on the states to do what they're doing, then we have that greater assurance, right, that we're not going to be doing that battle. So anyway, thank you. Let's see, Lynn and then Morgan.
Yeah, just quickly, the Brown-McKenzie research that was inherent in the task force report in Oregon, this was the best workaround they could find for ERISA, the payroll tax, and they felt that this would be the best insulation, but certainly no guarantee that it wouldn't be challenged in the courts. So you're still putting your neck out, anyway, without that waiver.
Yep. Yeah. Thank you, Lynn. Morgan?
Yeah, the way the New York bill is written, that it is based on a payroll tax, and the sponsors feel pretty confident that it would not violate ERISA. But and so we're obviously moving ahead trying to get the bill passed without a waiver initially in regards to ERISA. which is not to say that we would oppose, waivers being developed and that might be beneficial to other states. It's just with our state bill, we feel as though our sponsors feel as though that should not be it should not be a violation, essentially. And our bill also does act as sort of a wraparound. Potentially, if we don't get the federal waivers that we need, it would act as a wraparound bill to those programs. So that's already written into our legislation as well. But again, we would try for the waivers first, because it would certainly simplify and reduce the cost of the system if we do get those federal waivers. So it's something that we will pursue as soon as the bill is passed. It's something that we would pursue immediately, but we don't feel like it's a barrier to passing the bill.
Right, but the cost may be prohibitive if you have all those new lines of payers, right? So that's anyway. Thank you, Morgan. Appreciate that. Yeah, and you're doing great work in New York, and let's just keep the conversation going. We want to make it as helpful as possible for all the states to go forward seamlessly with implementation of universal health care. We're at 3:45 right now. I think we're good. And I hope that we've answered all your questions. If you have further questions, more questions, you can reach me. I'll drop my email, cpennacchio@gmail.com. Mike Huntington's our secretary. Mike, you want to drop yours in there as well? mchuntington@gmail.com. Can you do that for us? And then I just want to thank all of our panelists as well as our participants, Barbara, Lydia, Lynn, Ann, Morgan, Linda, Maureen. And all the support folks, in this conference. You're amazing people. We've got a strategy here to win, and we really do need to be mindful of all the different steps that we're going to need to take. And that includes having a permanent, again, dedicated presence in Washington, D.C. I think we've got to be on the ground. One of the things I learned I went to a reception last fall and met up with Rokana, paid $100 that I don't have. I live on a Social Security check. And I approached him and he gave me 10 minutes. He said, "You're with OnePayerStates, huh? Tell me more. We've been working with your healthcare LA for the last 3 years and you don't know who we are." I mean, that's the point, is if you're not present, you're not recognized. Out of sight, out of mind. You've got to be present. So I'm going to be talking to all of the critical national organizations, and we need to have that permanent presence in Washington, D.C. in order to be taken seriously. And then we've got to grow our movement across all the bands of social justice. We have the plan. We know what needs to be done. Now we just need to roll up our sleeves and do it. Thank you. Everybody, thank you so much. Stay tuned.